So now on to the main attraction. Today's webinar will provide a high-level overview of the recent NPRMs that have come out impacting the health IT space. Then it will be followed by a panel discussion. So if you'll recall, during the registration for this webinar, there was a part of that forum that we were asking for your questions. So our panel discussion has been crafted based on the questions that you guys asked, and we got a lot of questions. There were some themes, so we kind of grouped those questions together, and I hope that we'll be able to cover most of those either during the main presentation, because some of them were related to timing and things like that we're probably going to cover in the main presentation. Those that weren't going to be covered there, we put into the panel discussion section. If you realize that the question that you asked didn't get explicitly answered, feel free to reach out to us after the webinar. We're happy to try to answer that over email or set up a time to chat. All right, so now let's move on to meet our panelists. I will let them introduce themselves. However, I will note that one of them, we are missing Pooja Babur today, unfortunately. She went over to Health Data Palooza last week and picked a bug up. So she's not feeling well today, and we wish her well, but we still have Jocelyn Keegan and Kim Boyd with us today. So Kim, do you want to introduce yourself first?
Yeah, absolutely. Josh, you want to forward to the next screen for me? So I'm Kim Boyd. I am a contractor here at Point of Care Partners, and I lead the Regulatory Resource Center team, and I'm the co-editor and editor of Interoperability Outlook. I am also a 25-year health information technology and policy SME, and help coordinate on the use case for Codex and prior authorization. Jocelyn, I'll hand it to you.
Awesome. Jocelyn Keegan, I'm the payer practice lead here at Point of Care Partners. I've actually been with POCP crazily about 7 years. I've got about 25 years experience building stuff. I like to refer to myself as a recovering product manager. And here at POCP, I spend my time basically working with our payer, provider, and vendor clients, really at the intersection of where technology, strategy, policy, and standards intersect, and get to help people figure out sort of their path forward, their go-to-market strategies, and just general advisory services in this space. In addition to that, I spend time running the Da Vinci project, which is I'm the program manager there, and we have a team of about 30 part-time SMEs that basically work with the in-kind resources from the industry. We'll talk a little bit more about accelerators as part of today's presentation, but really make this work possible. And a lot of the content today we're discussing is based on this really industry-first movement. So I'm super excited to be here to see sort of the work product becoming real through the proposed regulations that we're going to discuss today, and eager to hear from you guys as we're presenting. We'll try and make it sort of as interactive and be able to catch questions, to Melissa's point, sort of as we're going. And with that, I'm going to dive straight into the meat. The way that we're doing the session today is Kim and I are going to do a brief overview of the NPRMs and sort of what's in flight. Then we're going to actually pause for a minute and sort of do a little bit of a lens pullback around sort of what's happening within the FHIR community overall, and other aspects of industry updates that are happening and places for you to get engaged. And then we're going to reserve the portion for Melissa to pummel us with questions. I mean, we're going to have a facilitated discussion about some of the, I would say, more sort of word on the street, practical implications to you guys as implementers out there in the industry about what's packed into this NPRM work and the much larger landscape beyond it. And I look forward to a lively discussion. So I think we, I don't want to say that there was any surprise to us getting rules in December. I think that both the rules we're going to discuss today, both the one on attachments and the one on the broader burden reduction space, were long awaited. The attachments one, I think you could put long awaited, right? People have been waiting for decades for traction there. I think that, the fact that we were in sort of this limbo, I think, over the last couple of years, waiting for sort of activity in these spaces, and now we have something to react to as an industry, and there's lots of conversations going on. And so we're going to sort of do a little bit more of a factual basis of sort of what's in the rules, what are the considerations, and then we'll talk a little bit broadly about sort of what does it mean, what do these things mean for folks, as we get into the discussion portion. So if we look at CMS 0057, advancing interoperability, improving prior authorization, I think that maybe if I were going to say at the very highest level, there's not anything that's really a surprise in that rule from a content perspective, because it really is, we're being revisited by the Interop 2 rule. We're referring to this rule as Interop 3 out in the industry. The first rule being the patient access API rules that came out, probably 4 years ago now, and have been well in implementation for a couple of years now by payers in the industry. And we're going to look at sort of the 4 areas of where APIs are being required. But if we look at the core of the rule overall, we're really looking at this being about sort of laying out that required use of FHIR for payers and a subset of providers. This idea that the APIs need to be FHIR based. So really this movement, this ability for us to be able to understand what's happening around some of the transaction sets, especially metrics and reporting around prior authorization. And I think a really important part of this rule in general is this idea that we need skin in the game from the provider side. So basically getting providers through MIPS to actually participate and have a requirement to use EPA. And the overarching elements of the interoperability program, and then Kim's going to unpack some of the RFI. So I'm going to spend time talking into the 4 main APIs that are going to be discussed. And I think if you think about sort of the scope of this rule, although it doesn't directly relate to Medicare fee-for-service, CMS wants to ensure people that Medicare is looking at and looking to follow these same proposed policies within their own world. And have, I would say, intoned from sort of their perch while out educating people about the rules, that they want to be considered a leader here and a thought leader here. So I would interpret this as sort of them acknowledging that they're going to have CMS overall as an organization also eating their own dog food for these APIs that they're proposing for the industry. If we think about the scope of the work itself, it's we're not looking at changing anything about the HIPAA covered entities, but that there is going to be a need to be able to do certification and identification about who the requester is, and the data for payers for some of the payer aspects that we're going to unpack. And that really, if you think about this is a foundation that's been happening over a series of years between ONC and CMS, and we'll sort of unpack some of that visually for you as we get later into the presentation. But if we think about patient access API as being a building block, sort of this is the next layer of that building block as we start looking at the APIs themselves. So not surprisingly, what we're seeing here is CMS coming back and really codifying aspects of the patient access API as part of this step of the rule. If we think about this, it's really making sure that people are executing on the intent of the initial rule. It's starting to get reporting based on the usage of those APIs and the accessibility and the ability to understand what data is flowing through those APIs that have now been alive and used in the market. And I would guess that this is a little bit of a foreshadowing too, that we're going to start to see enforcement around people making sure that those APIs are up, they're compliant with FHIR. And we'll talk about this through the course of today, really, sort of the absence of a named standard, but a list of recommended implementation guides coming out of the CMS organization to be able to support this work. And then with the next aspect from an API perspective, the next API is really getting around taking and lifting sort of from those foundations of what was required for the patient API and making those same services from a payer available to providers. And so this is the ability to share that claims and account data, not the pricing data, no information about cost for this audience, of course, but essentially that core information that's available in US CDI today. There's also requirements around the ability for people to be able to opt out having their data shared. and then basically the accompanying educational requirements around that. I think what's new here, though, in addition, is the inclusion of attribution, and I think that that's a recognition of adoption patterns and just the realities of as the initial APIs have now been up and used, feedback coming from the market to CMS around really being able to make sure that you can get identity right from a patient perspective. And progress, I think, again, in the emerging standards coming out of the FHIR community, there's an attribution implementation guide that's now been added to the list of recommended guides that we'll talk about in a little bit. And then payer to payer was actually in the previous rule, but was the implementation requirement was held off after CMS, I think, received some really valid feedback from implementers of patient access API that some of the ways that the initial payer to payer requirement was written without a reference to FHIR would create sort of a little bit of baggage that would follow us for many years of unstructured data being sort of released out into the industry that wouldn't necessarily be usable, but to create challenges for both providers and payers alike if all of a sudden this information was sort of in flight for perpetuity. And so I think you'll see in this next version of the rule, this idea and this acknowledgement that payer-to-payer data exchange is critically important. There is some nuance, I would say, from a feedback perspective of what we're seeing in the industry around how, again, that sort of matching and member consent piece is happening. That's different than patient access API. It heavily relies on OAuth. OAuth won't work if the patient isn't involved in a payer-to-payer transaction set. So we're seeing feedback from the industry around sort of how to deal with that versus what's in the proposed rule. And I think that there are questions that are being mounted of sort of, the turnaround time of the data and some challenges to make sure that we're handling, I think, more gracefully concurrent coverage and making sure that, that payers have the ability to be able to clearly see, how and when they're on the hook, sort of when there's coverage. And again, opt-in is what's in place here. And so, I'm expecting that we'll see feedback from the market as well on sort of the challenges around the opt-in model. I think if we think about this from an implementation perspective, the delay, I think earlier in the payer-to-payer implementation, sort of the pause, I think people had anticipated that this would come back with an earlier timeline and an earlier implementation deadline. All of these regs have a 2026 implementation deadline, sort of a big bang effect. And so again, we anticipate, there's many payers that had invested in the payer-to-payer FHIR solution back when it was first required. And I would anticipate you're going to see feedback of folks wanting to make sure that that gets sort of delivered in whole. I'm not clear that we'll see anybody asking to do anything earlier, but I think a call out that people are ready to start that step. And then the third sort of API or APIs that are referenced, the fourth API that are referenced here is this idea that how do we take this bundle of work that's happening around I'd say the promise to really start to automate prior authorization in a meaningful way on the medical side of the house. And so if we think about the work that we know is happening out there in the industry or in Da Vinci, the CMS team, very similar to the previous rule, are really lifting on and sort of marrying sort of the functional requirements of the coverage requirements, discovery, documentation, templates, and rules, and the PAS guide to be able to crosswalk this into a bundle of services that they're naming prior authorization requirements, documentation, and decision that we're affectionately referring to as PAR D, emphasis on the PAR D end of it from a humorous standpoint. But I think what's important to say is that I don't think there's anything strikingly different than what we saw in the original rules here, and that conversation that's happening in the industry is going to be in a more technical nature around individual nuances of ways things are being positioned inside the guide. But if we look at it, it's really that ability and the expectation sort of on, by 2026 that people are going to be able to stand up all three services, and that in addition to that, they're going to need to include the reason for denial, I think the timeframes, we're going to see a lot of commentary around on this idea that, prior authorization needs to happen within 7 days and expedited needs to happen within that 72-hour turnaround time. And really this focus on the decision metrics. And I'll add a little commentary here to say that, this isn't dissimilar to what's being required for the folks that are participating in the X12 exception process that are doing pure fire versions of the Da Vinci Guide implementations. This idea of what is the turnaround time? What is the improvement that we're seeing? What's being approved and denied? Are we actually adding value in the workflow and reducing burden? I think is really what the intent is around the metrics here. And so, as I mentioned before, if you look at sort of what is happening from an industry perspective, I think we're seeing, an emerging pattern in this building block activity that's happening both, sort of from two hands, from the ONC side of the house and the CMS side of the house. CMS is laying heavily on the groundwork that's been created by the certification work that ONC has been doing with the EHR vendors over the last, decade. And so the things that are checkboxed here with the blue, I'm just going to take a little bit of time to talk about differentiate sort of why things are checkboxes and why things are X's. And the majority of the reason that this looks the way that it does is really about where we are as a point in time with these individual guides and the versions of these guides. So the things that are checkboxed are things that have already been named in a certification requirement from an ONC, are actively in use from an implementation perspective because of those requirements. And where we're seeing a proposed or a recommended guide, these are newer versions of guides that are still in flight and being developed to, I would say, sort of their base functional capability. Unlike ONC, who can update and name new versions through certification, CMS at this point in time is really controlling what version of a guide somebody is using through regulation. So once they name a version, they basically have to reissue that regulation to get the floor to move up to the new version. And so if you've listened to any of the commentary coming out from the CMS team, I would say you've seen them very sort of leaning forward in their seats to explain, we are highly recommending, like, I don't think they're looking for anybody to go off and find different ways to do this, but they're very vocally acknowledging that we're in early days here from an implementation standpoint, and that these guides are going to continue to evolve and grow. And so they don't want to peg anybody to too early a version of the guides as they evolve over the next, 5 to 10 years. So I would anticipate that, as we're seeing sort of patterns of reference then named, you're going to continue to see that pattern move forward. And then the other piece of commentary I would add, and Kim can put me back in my box if I need to be, is I also see movement afoot from the continued coordination of ONC and CMS with, blog posts and commentary coming out of the administrator and out of the ONC team about really expanding the scope and the capabilities to do additional certification beyond the EHR vendors. And so I wouldn't be surprised if we're moving into a trend of CMS, following the SFAP lead and following the certification pathway and getting out of naming versions and regs and really looking at, how do we actually start to have more of a certification or demonstration, and then compliance and then certification, then enforcement model that ONC has been in, really since the beginning of meaningful use, and shifting away from sort of this locked in world that we get to in our existing X12 and CPDP state, that a new version has to be named in order for everybody to move the floor up. So sort of lightning sort of processes, but that's speculation on my part. I'm just sort of watching and listening to the conversations that are happening around us. Is that Kim, is that too far afield to make that statement?
No, I think you're right in the right box for sure. And if you want to go to the next slide,
yep.
I think you highlighted this collaboration between ONC and CMS and their ability or their attempt to really align with one another as they think about their strategic plan on interoperability and where they can complement one another. And I think you see some of that through this whole RFI process that's a part of the NPRM for the Interop 3 rule, as you notated earlier, right? Because it does highlight not only their collaboration, but even collaboration with other agencies throughout HHS. And we've seen it through different tea leaves, right? And reading the tea leaves, but they are working to align their strategic plans and their priorities. And like I said, you see it in some of the RFI here, and as it focuses on very specific patient and social needs, right, that the HHS agencies have talked about, like addressing social determinants of health and maternal health, and what are the data population data capturing metrics that can be captured through this growing data fluidity model that they're pushing for, that will help inform future rulemaking and future opportunity, like USCDI version 5, USCDI version 4, as you think about how that type of policy works. So this particular NPRM, there were several RFIs, or 5 specifically, requests for information, in addition to responding to the API callouts that you were just talking about, Josh, right? So how do we exchange more fluidly information for behavioral health, for social determinants of health? Could this apply? Could this process, or should this process also apply to fee for service, as an example? But I think most definitely when we think about the latest announcement coming out of ONC and the 6 QHINs that were just announced for TEFCA, right? How could, through this rulemaking, CMS rulemaking, support that advancement of TEFCA? So those were some of the components of the RFIs toward the very end of the NPRM to address other parts of the healthcare ecosystem and that alignment that you talked about earlier, Joss. I think depending on, and you mentioned also, comments on the NPRM today, I think depending upon the volume and the density of those comments to be received, and again, the reminder, comments are due March 13th for this particular NPRM. But I do think that depending on, again, volume density, I think when I looked yesterday, there were 175 comments to the NPRM already. I think that will be an indicator of when we should expect a final rule to be published past that comment period. I think the agency has been pretty frank on their intent to move forward with this particular rulemaking and other interoperability. So I think stakeholders should anticipate the agency to turn their review around of this NPRM pretty quick. In evaluating, taking a look at the comments that have posted already and evaluating those comments, I haven't seen a significant or comprehensive details. Most of the comments have been pretty benign so far, mostly around the turnaround times that are being proposed in the NPRM. And I was really anticipating maybe the date issue, the effective date issue, but really haven't seen a lot of comments on that yet either. So right now, 1/1/2026 is what I think most impacted entities and their partners should be prepared for. But we will be holding, and Melissa will talk about this a little bit further, we will be holding a webinar on April 6th to kind of break that down a little bit further. Anything you want to add there, Joss, before we go to the next?
No, I was going to move us to the next slide. I'm just watching our time. So.
Healthcare attachments. Yeah. So as Jocelyn mentioned earlier, the healthcare attachments conversation has been going on since HIPAA, right? So about 27 years now. But on, December 21st of 2022, the Department of Health and Human Services did decide to issue a proposed rulemaking to talk about the regulation of standards for healthcare attachment transactions. These include, transactions for medical charts, x-rays, and other procedures. So it's been a long time in the making, but back when this first came out, I think DVDs were in fashion for transmitting information or copying information, for those of you who are familiar with DVDs. However, there never really was a standard name or actually even enforced as a requirement related to attachments. So if this particular one is finalized, this would apply to all healthcare transactions and attachments for those transactions, as including healthcare claims and even prior authorization transactions. They're also talking about the adoption of an electronic signature to be used in conjunction with those attachments. So, we think it's really important for everyone to really take a really close look at this particular NPRM. And I think also the timing of this NPRM as we are talking about FHIR APIs and standards-based APIs. I think it's really an opportunity for organizations to lean into more modern advances in standards interoperability. So go ahead, Jocelyn, to the next slide, and then we can talk a little bit more deeply, if you don't mind, on some of the layout. Comments are due March 21. Josh, please chime in. But this right here really lays out the different business operations and the proposed standards and or guidelines that are being called for these business operations. So you see the claim and attachment request. It's the 277 request, and then you've got the non-claim related, which would be in the new version 6020 is what they're looking to utilize in this proposed rulemaking. And then of course prior authorization is the 278. Jocelyn, do you want to talk a little bit more deeply about the CDAs and the CCDAs a little bit?
Yeah, I mean, I think that from the standpoint that we're in now, I think we're in a period in time where we've seen adoption of the CCDA broadly as a transport for clinical data that's being shared, often in response to things like risk and HEDIS. People are doing chart polls, they're paying for chart polls. I think that you're seeing pockets of adoption. The NSG group or NGS group at Anthem, now Elevance, has actually been really successful, I think, in some industry leading work, really putting this paradigm to use in the industry. But what we're seeing, really is a continued use of sort of non-standard, non-CCDA attachments happening in the claims world today. And as many of the folks on the call know, we really have seen sort of a stall at about 10% of adoption around prior authorizations in general. And that, that content that's coming in for supplemental data for authorizations is still sort of strife with workflow issues. Part of the reason CMS has been helping to invest in in-kind resources, I think, into the Part D side of the house is sort of this known challenge of matching the clinical data or reducing the amount of clinical data that's needed for prior auth. And so, I think that, again, we have a base of adoption, I think, for specific workflows. The one comment that I would make, maybe in addition to the CCDA side of the house, though, Kim, is I think that people were surprised not just at maybe what was named and how it was named, but also that expansion to health data and not just the claims and prior authorization space. I think that we'll see a lot of commentary, I think, around that expansion in sort of what content and for what workflows the transaction set is in mind for. I think that we'll get into it, I think, in the discussion, sort of the pros and cons of, what's the difference of, using and leveraging CCDA and the X12 transport transactions here, in contrast to some of the other direction that CMS and ONC have been headed to more of a modern API-based approach with FHIR.
I agree, Jocelyn. You want to go ahead and go to the next slide? I do want to leave time for where we talk about the implementation timeframe. And I know we're talking a little bit more about the healthcare attachments. There are some specific comments that were solicited. And Jocelyn, you brought some of this up too, right? Is around FHIR and FHIR resources. So they are asking through the comment on this particular attachment rule, are there other standards or alternative approaches that are in development that could be used, like the FHIR Clinical Data Exchange or CDEX, right? So they are also looking for comments from the industry on other opportunities besides what's being called for in this particular rule to move the needle on this type of information exchange and extraction. So we are actually finalizing our comments to Health and Human Services, as consultants in healthcare IT. I think we do bring a unique perspective from the provider payer health IT perspective. So we will be submitting our comments very shortly on that. We're thinking through where we are right now in the industry and what we would like the industry to look like in 2 to 3 years, and what do we think it should look like in 2 to 3 years. And is it really, are we really near that point of codified structured data exchange versus some, level of attachment, Jocelyn, right?
Yeah.
Jocelyn, you did mention, we do recognize that CCDA is currently the most commonly used format for this health information exchange. And we absolutely appreciate, that healthcare stakeholders have invested in this and using it successfully. So without, without regulatory push, if you would. So we do recognize that. And, we're hopeful that while administrative simplification is not perfect, these NPRMs and activities that innovators in the market are doing are moving us toward more codified and structured information. So not perfect, but it is an improvement over facts, if you would. Go ahead to the next slide for me, Joss. I want to talk a little bit about the CMS script and real-time prescription benefit NPRMs that also came out in December. So in this particular NPRM is tied to the prescription benefit side of healthcare, right? So the script, NCPDP script standard focuses both on e-prescribing and electronic prior authorization. And then the real-time prescription benefit standard, while there's been real-time prescription benefit tools in the marketplace, there's been no call for using a particular standard like the one that was developed by NCPDP. So this particular NPRM does look for an effective date of January 1, 2025, and we'll look at a timeline graph here in just a moment, but I want you to be thinking about all of the different things that need to take place between now, January 1, 2025, 2026. And that is inclusive of organizations that do use the script standard for processing prior authorizations, as an example, on the prescription benefit side. But they are calling for particular versions of the standard. I will say that Point of Care Partners has already submitted our comments. I know that we have asked Health and Human Services to use the most current up-to-date version versus the ones that are called for in this NPRM. For example, the script standard 2023-011 version versus the 2022 version, because there's been several enhancements that have been made that are helpful for those stakeholders who are processing prescriptions and electronic prior authorizations on the prescription benefit side. As well as the real-time prescription benefit standard, the one that is being called for. We feel that there is a newer version. So version 13 is what we've recommended when we submitted our comments to CMS for this. So I do anticipate that the 1/1/2025 timeframe will likely stay intact when they do come out with a final rulemaking. So I think stakeholders should be prepared for that. And we mentioned earlier too around this potential move for greater certification. So I think stakeholders should be prepared for ONC to come out with either a voluntary or even required certification for the script standard and the real-time prescription benefit standard, but at a minimum for voluntary. And I'd probably be looking in the 2026 timeframe for that, maybe 2027. So just a little bit of nugget for you there. Joss, anything you want to add here?
No, let's go to the sample timeline, because I think that that'll allow us to pivot the conversation a little bit.
Yeah, go for it. So as part of our Interoperability Outlook subscription, we went through the process of evaluating and digging into all the NPRMs, and really from a timeline perspective, what stakeholders really needed to be thinking about in the timeframes and phases in which they needed to be thinking about this type of implementation. And this particular one really is around the Part E APIs, right? So we're not taking even into consideration the payer-to-payer, payer-to-payer API exchange, the provider directory access API exchange, and even patient access API. Now layer that with the real-time prescription benefit and the script standard details we were just talking about. This timeline, this graphic could get very busy very quick. But we wanted to break down for you these different phases, what you really should be thinking about right now, because 2026 for at least the Part E API is really not that far off, especially when you take into consideration the other implementations you need to be thinking about. So you really need to be in phase one right now and assessing and analyzing, understanding these rules and requirements. And we're grateful you joined us today, and hopefully this will help you understand them a little bit more deeply. And conducting systemic analysis, data and system analysis of what you have today and where does it align or not align with what is being called for in these NPRMs, and working through that workflow analysis. What might change with your workflows, especially if you're an EHR that's supporting, a provider to do prior authorization, right? Or a vendor who's helping that EHR to provide that workflow and that user experience for a provider to get through this automation for PA, which is so needed, right? But if you don't have a vendor, do you need a vendor? So you need to be analyzing that like right now, and then getting into that decision-making phase and deciding whether or not you need to build, do you need to buy, do you need to partner with someone to make this happen, and look through that selection process. And that is not a short process, right, to get through that contracting process. So you really need to be thinking about that, and obviously budgeting and then contracting, which I mentioned. And then you get into the execution phase and designing and working through that development and testing, which we'll talk a little bit about the accelerators, but that's exactly what we're working on over here in Codex. So Jocelyn, do you want to add some detail about the buffer or anything else you want to add to this timeline?
I guess I'd want to do a little bit of a lens pull back when we think about this. So part of the reason that we sort of put our brains around this and said, like, again, we're POCP, so we need a visual, right, description to really drive home these points to folks is, if we just look back to patient access API, you can either make a strategic decision to be investing in sort of building these core services and this move and shift to APIs and, sort of breaking down all the different places that you can get sort of this data in workflow to your organization and to your partners, or you can do a check the box compliance exercise, right? And we know organizations do both. And so, I think when the rule first came out, everybody was like, 2026, that's so far away. And I watched my colleagues at CMS sort of field questions in the first couple of weeks, Dr. Green and Alex Muggy, and they're like, we listened. Now, I am literally probably one of the only few dorks that actually read all of the comments that came back on the pulled interop 2 rule, and people talked about that they needed more time. I think CMS is listening here, right? And to Kim's point, this isn't just about implementing the 3 prior auth guides. This is about implementing 4 separate APIs, starting from scratch if you didn't move to APIs for patient access API already. And they're like literally giving us breadcrumbs, right, as an industry about where they're headed and the direction that they're headed. And that when you back into that, right, you just do some basic planning and you think about doing this in a strategic, thoughtful way, then today, if you haven't started, you need to get your acting gear. And that was really, I think, that both the intent of being able to sort of make the point that 2026 go live is not that far away for everyone, but also even just as a conversation piece for you guys to have within your own organizations. I had a funny interaction. We were showing this a version of the slide to some folks in some blinded interviews last week, and the comment was, well, if this is from the vendor, I think it's just the vendor convincing me I need to buy now. And we're like, well, no, we created this because we want to show people what the timeline really looks like. And I think that, we all understand it takes us longer to do things than we ever think it's going to. And so being able to do that abstract to say, how am I going to do this across the lines of business and not only implement the technology, but the business processes changes and opportunities, take advantage of the opportunities, so this isn't something happening to you, but it's a way for you to modernize how you engage with your partners internally inside your organization, but also, the folks that you're working with out in the industry. The only other comment I would add on here too is I think one of the ahas that I've had in sort of digging around and listening to the questions that are happening out in the field is how fragmented these services are inside of your large complex organizations or customer organizations, and the level of carve outs and all of the places where data resides inside your organizations. So, or in your side of your clients' organizations. So that bigger picture sort of to platform or not platform, or understanding how each of these vendor partners is going to be able to make you compliant as a payer or a provider, I think is a really important question for you to get a handle on now, versus sort of starting those conversations with a 2024 or 2025 budget item.
Yeah.
It
Great
seemed
call
more
out,
doom and
Jeff.
gloom than I wanted to be, but
There's so
I think
much
it's
more.
important. Yeah.
It's so much work. Let's go ahead and move. So you were talking about engagement. Let's quickly move this so we can get to some panel discussions. And
Yeah.
Josh, if we can cover a little bit some of the
Yeah,
organization.
just really high level. I think that one of the things we always want to impart to you guys is how many places these conversations are happening in the industry. So if you want your feedback heard, know where you have membership and know where you should be advocating, because we can tell you the entrenched interested parties are on those calls and they're making viewpoints heard, right? So, if you're looking to advance the industry and you want to move forward, there's active conversations happening within the work groups at HL7, at X12, at NCPDP. We'll talk about that. But if we think about the role of the standard development organizations, slow myself down enough, they are internally, coordinated and working sort of alongside all of this regulatory work in flight. Do you want to talk, maybe just do a second or two sort of on
real
the
second,
accelerators for folks that don't know about it? Yeah.
No, yeah, these are some of the industry groups or MSIs that we talk about in the accelerators and fire activity that's happening. And these are just some of the examples of the convening and engagement work that this co-collaboration is happening across the industry. Obviously, Da Vinci right here, third bullet down was probably the catalyst behind the NPRM, the Interop 3 rule. But there's also activity going on Gravity around social determinants of health and the Caring Alliance on consumer-facing RTPB. So we just really want to, get folks involved here and look at opportunities and how all of this work and these APIs will help us as we continue to move our work forward. Jocelyn, if you'll go to the next one too. We wanted to go ahead because this will be shared with you all post webinar, but here are some of those other areas and other associations and where conversations are taking place. And those links will be provided to you, like the HITAC committee, which is ONC's, health information and interoperability committee that looks at all interoperability across ONC. So we'll provide this to you post webinar today.
And I would do a call out, that industry survey from WEDI, they have been blasting folks to be able to give responses. And they're really looking for, I think, a really good representation of feedback of where people are in regards to both of these NPRMs, to make sure that they're getting a really holistic set of feedback, not just the folks that have staff that can actually come and attend their calls. So I think that's important. And the only other call out that I would make sort of to wrap up the conversation, I do think that we're in an interesting point in time, and some of these artifacts that you're seeing are content that Kim and myself and others use as part of that interoperability outlook advisory service that Kim mentioned, that Melissa's going to tell you guys a little bit more about. But I think what's important is that there's so much happening, and how do you monitor it all? But that we've moved to a point where you can see that the regulation really is following the progress in the industry. So Kim's point about sort of Da Vinci being leveraged and Karen being leveraged, and the guides being referenced and sort of built off of products and artifacts coming out of the Argonaut project. This really is about industry leading and regulation following with alignment. And I think that that's a sea change for us as an industry, and you need to have your voice heard.
Thanks, ladies. So I just did want to kind of circle back and mention that we are having another webinar on April 6th. And this one we will have done an analysis of the comments that have come in on these NPRMs to kind of get some themes for, what folks are saying. And obviously that gives an indication of what might be in the final rule, because if everybody is saying a certain thing, usually it gets addressed in some way, shape, or form. So please join us for that webinar. You guys are getting a sneak peek and being able to register for this early. So you'll get the link when I send out the slides. If you'll go to the next slide. One of the questions that we actually got from a registrant was, what are resources for me to stay on top of like what's happening with policy and what's happening just in the industry and the fire community? And so we did provide some links for organizations that hold regular events or regular meetings where you can provide feedback or at least listen to the direction that they're going, and try to have that interaction. But we also offer the Interoperability Outlook subscription service, which is a quarterly report that gets sent to our subscribers that breaks down all of the different kind of policy nuggets and tea leaves, and also specific breakdowns of NPRMs and final rules and timelines and things like that, in addition to giving a recap of what's happening in the fire accelerator realm and the standards development realm. and other industry organizations. So if you're interested in learning more, the link is right there, and you can also contact us. And then we can get into our panel discussion. Oh, wait, one more thing I forgot to mention. We're going to be at HIMSS. No, keep going. Next one, sorry. We are going to be at HIMSS and Vive. If you want to schedule time with Kim, Pooja, or Jocelyn, these meeting links, which again, you'll have links to when I send the slides out tomorrow, you can actually book time with them face-to-face at those meetings. So please do so if you have like specific unique challenges in your organizations that you just want to, have a thought partner with and help you think through. We're happy to have those conversations and see if we can help. Now we can get into the panel discussion. All right, so again, all of these questions that we're about to go through, and Jocelyn, you can stop sharing if you want to, and we can just go to video since we're just going to be chatting. So all of the questions that we're going to kind of go through were submitted. They got a little bit more specific, but I kind of grouped them together and kept them a relatively high level. So Jocelyn and Kim can kind of respond to them and hopefully answer the more specific question as well. So during the presentation, we did cover some timeline related stuff. And also, the timeline looking at execution and becoming compliant, things like that. We did get some questions about certifications. And specifically whether any of these NPRMs will change the certification. And then we also got another question from the audience while you guys were talking about whether or not CMS is going to move to requiring certification, or is that more close relationship between CMS and ONC going to look like ONC picking something up and putting it into certification? Do you have some insight into what folks need to?
I can start and let Kim sort of tag on. So I think that one of the things that we've heard a lot for folks is like, especially because of sort of where we're positioned in the market, like why didn't they name the guides? Why didn't they name the Da Vinci guides? Why didn't they name the Karen guide? Why aren't they picked, right? Why are there X's next to them? And I think that I try to unpack that a little bit, which is it's about timing, right? We know that people are actively implementing these guides. They're going into production with these existing guides in the format they're in, and there's I'd say almost like a trend, and there's a lot of conversation happening in the industry. I think folks that are on the EHR side that really understand sort of the weight of certification and the readiness for certification are concerned about sort of like write the rule, require it, certify it, right? Because there needs to be a period in time that we're learning from those implementations, right? We're going to learn a tremendous amount. Those guides are going to continue to evolve. And I would use actually the work over on the pharmacy side of the house that Kim was talking about with RTBC. We've had adoption of guides, both on the prior auth and on the RTBC side of the house and the e-prescribing side of the house without a heavy certification arm. And that's moved forward. We've had other places where we really need to have a certification requirement. Today, most sort of attestation around compliance with the version of the HIPAA name standard in a CMS rule is done through CAQH Core. And that's a voluntary process where both payers, vendors, providers opt in to show that they meet the requirements for core certification. And that happens sort of more on a demand basis as the operating rules have evolved. That is a more static process and moves more slowly. I think that based on industry feedback, both the NCVHS and ONC over a number of years, really this idea, and I think the core behind where the ONC team is headed with SVAP, which is the standards
version advancement process.
I was like, what's the V? Version advancement process. Thanks, Kim. My brain's too busy these days. Is really this idea of let's establish a floor, but let's not penalize the people that want to innovate to be able to advance above the floor. And NCBPB has actually done this for years in the way that they move forward with versions. And that's happened informally in the FHIR space where individual trading partners will do more and above. And even happens in the X12 world where people are doing proprietary solutions on above or beyond sort of what's in their core X12 offerings, right? So I think that the idea of rather than having sort of the fragility of everybody sort of rolling their own and figuring it out, that they're saying, okay, let's give people a pathway so that there's a way to advance. I don't think that anybody from CMS has said that that's what they're going to do, but I think that there was a blog post last summer that talked about sort of expanding the scope of who ONC is overseeing. And I think that the tea leaf around there being an EPA RFI that asked about payers and providers, right, is happening. And I think everybody's sort of in a different learning curve about what it really means to be certified. So I don't think it's something that's imminent, but I would just say that if I were betting, I would expect that we're going to see more than just the EHRs sort of be in the realm of certification as we go through the next 4 or 5 years in the industry.
Okay.
I don't know, Kim. I don't know if you want to disagree with me there, but I feel like that's where we're headed.
So, and I apologize, ladies, because I am going to jump around our discussion guide a little bit because we only have a certain amount of time. But so why don't we go ahead and talk about the prior authorization portion, because we did get a couple of questions around wanting to know, because there have been wanting to know the adoption rate for prior authorization functionality. And Jocelyn, I know that you have some insight specifically working on DaVinci on that. And then Kim, there was another question that you may have some commentary on, which is just the how does Medicare Advantage rulemaking on EPA? What does that look like, and are we seeing anything there? So, Jocelyn, you want to go first?
Yeah. So if we just think about real world adoption, and I think this gets at the crux of sort of the collision of the attachments rule with that interop 3 rule. Because basically sort of the attachments rule is saying status quo, pick up and even expand the use of the concept of an attachment, right? Beyond sort of in a vacuum of another part of HHS, CMS saying, hey, we're going to roll out this way to reduce and get to the complexity of prior auth across sort of 3 transaction sets. And the reason I pull that point out is I think we've got a lot of traction in the industry with people implementing CRD, just basic information about, is a prior authorization required? Almost I would say we've been saying since the beginning, it's sort of akin to that RTBC BP transaction set. This idea of like, just give me more transparency about what's actually covered, or if this is covered, or if there's any steps that I need to go through to get approval, to payers and vendors, I would say at this point in time, and the EHRs, not so much the providers, are looking at how would they actually start to upend those rules and make them codifiable. And so there's been a lot of background activity that's not visible to the outside world of payers, providers, vendors, including the EHRs, figuring out how would we actually expose the rules that are required in DTR, in document templates and rules. And I think documentation templates and rules. And I think that what's important there is that if we look at where we were even 2 years ago when the first rule dropped, the traction of the industry with that rule dropping to show that that is actually where sort of the bets are being played has been there, but we were in limbo, right? People were like, we know what our plan is, and once the rule drops, we're going to get started. So now that the rule has dropped, we've watched payer organizations, the vendor community around prior authorization has exploded. And we've seen sort of stalwarts, right? People that have been in the prior auth space for years start to really pivot to figure out how they're going to API enable their existing solutions.
Yeah. I agree with that, Jocelyn. And Melissa, I think you mentioned Medicare Advantage. They're included in this notice of proposed rulemaking this time. I think that was one of the things from the 2020 proposed rule that came out, right? Medicare Advantage was not in that particular one. And there was like, why? Well, in this particular NPRM, Medicare Advantage organizations need to be just as prepared to now move down this path of interoperability using these APIs as did the others who were previously named. So CHIP and Medicaid and qualified health plans are part of this NPRM for sure, and they need to be preparing for this next level of electronic prior authorization using APIs.
And I think that I wouldn't put too fine a point on that too, because I think we've learned as an industry that the solutions need to be all payer in order to get providers to use them, that providers need to be engaged and on the hook to implement. And I think CMS recognizes that. And I would even say the tone and tenor of the conversation in the industry isn't, no, we shouldn't do this. It's, how are we going to do it? What are the technical implications around some of this data sharing that needs to be worked out, right? As sort of scaling around FHIR really advances in consent gets
Right.
tackled in a meaningful way, beyond what's covered under TPO or needs to be covered beyond TPO. So um, I think that where the conversation is different than it was, materially different than it was 3 or 4 years ago. It's not how are we going to do it, it's what timeline and how are we going to accomplish it in a way that everybody can get to, I would say, the start line in a successful way.
Agreed.
Awesome. Okay, we need to move on because we've only got 2 minutes left. So I want to shift now. We talked a lot about, payer provider type of interactions and transactions. So I want to shift a little bit to think about some of the other stakeholders in the ecosystem, specifically looking at these NPRMs through the pharmacy lens. So with the pharmacist role kind of growing in the care team, how do these rules impact or change or set the stage, I guess, for that expanding role and the interoperability that we'll need to encompass that care setting?
Yeah, Josh, happy to take that one. So
Yeah, go ahead. Well, you go first.
Was I first? All right. So, the current CMS Interop 3 rule, which we just talked about really does not address medications, which was surprising. A lot of folks are like, not even addressing medications, but there's been a lot of advances, at least on the pharmacy benefit side and the pharmacy services side, not only in the electronic prior authorization and real-time prescription benefit side, but in care coordination. If you think about all the things that have happened with, the COVID-19 now endemic and pharmacists stepping into the more clinical related roles, there's this shifting wind within the standards bodies and through innovators who are going, how can we bring more data fluidity and more EHR-like opportunities to the pharmacy services arena through their pharmacy management systems to support that shift to more clinical-based roles for our pharmacists? And I know NCPDP is really focused on this endeavor through a new work group they're going to be standing up called the Coordination of Care and Innovation Working Group, which will start in August, which will really be focused more on the clinical services side of pharmacists being as a part of the care team, which supports value-based care as well, right? Which is what Da Vinci started on. So how do we build this ecosystem where there's more data fluidity between all of the care team, even though this particular NPRMs do not address that, but there are innovators in the market who are starting to do that. And I think even ONC in November had a HITAC committee meeting where they talked about pharmacy interoperability and care coordination. And there will be a task force that will be stood up starting in April by the ONC from like April to August to address what are the needs in the pharmacy interoperability space that ONC needs to take a look at to help support this continued evolution of pharmacists. I think one of the other things that most people probably don't know about when we talk about interoperability and data sharing and what Jocelyn was just sharing about, what are the rules, right? What do I need to know so I can move the patient through their care journey? There have been at least 10 states who have adopted legislation that requires data sharing similar to what we're talking about in this NPRM, which would impact the commercial space. Right. And those states are requiring that those entities that have the eligibility, cost, coverage, utilization management rules share that upstream with providers or patients or their third parties of choice. So that's where some of that vendor tech comes into play as well. So that not only addresses pharmacy related detail, but some of those pieces of legislation contain all detail. So
and I think this is a really important point that
we
Kim
actually
is making.
are.
Oh, we're out of town. You're going to stop us.
Yeah,
Okay.
sorry guys. I have to stop it and shut it down. Thank you everybody for joining us today. We are having that webinar on April 6th that will kind of dive into the comments and the themes. And so if we didn't get to some of the questions that we were going to talk about here, we probably will roll them over into that webinar as well because they're pertinent. So please register and join us again. We hope that this was helpful. Please reach out to us if you have questions or want to set up some time to chat. All right, everyone. Thank you so much. Have a great day.
Bye, ladies.